I'm going to go over a couple types of radiation. I'll start with internal radiation or brachytherapy, that's the radioactive seeds. And then after that I'll talk about external radiation. Brachytherapy, so the term brachy, either in Latin or Greek, means close. So it means putting radiation sources into or close to what you're trying to treat. In this country, the vast majority of brachytherapy is done with radioactive iodine. That's iodine-125. It's a compound that has a half-life of 60 days. Every 60 days, it gives off half of its radiation. This is a picture showing you radiation seeds in relation to a dime. So it shows you that they're very small. Those seeds or granules there, that whole thing isn't radioactive. It's usually a titanium capsule filled with a couple spheres or blocks of radioactive iodine-125. The way that a seed implant is done, so looking at these two pictures, the left is a diagram, the right is an actual picture. So brachytherapy for prostate cancer is a one-time procedure done in the operating room. Patients in the lithotomy position, like the childbirth position, and there's a rectum that's placed in the, there's an ultrasound that's placed in the rectum looking at the prostate. And the doctor who's doing the seed implant, the brachytherapy procedure, can see the prostate up on a monitor. And on that monitor is an overlay. And on the overlay is a grid with letters and numbers. And if you look at the picture on the right, this is a picture of a patient having a prostate seed implant done. There's an ultrasound in the rectum. Here's the scrotal area, so the scrotum has been lifted. So this is the area of skin between the back of the scrotum and the anus. When Dr. Bellani was talking about the perineal prostatectomy, this is the perineum. So there's a template, kind of a piece of material, and for those that can see it, there's letters and numbers on it. It's kind of like the kids' game Battleship. There's coordinates with holes. And what the radiation oncologist who does a seed implant is doing is they're feeding needles through the holes in that template and depositing seeds into the prostate under ultrasound guidance. And so each needle holds about 3 to 5 seeds. Typically an implant's about 100 to 120 seeds, so there's usually about 25, 30 needles that are going through this area. It's a procedure that takes about an hour to an hour and a half on average, sometimes a little bit quicker. Again, I mentioned it's a one-time procedure done in the operating room, usually under general anesthesia. Sometimes it can be done with local anesthesia. So as I mentioned, typically about 100 to 120 seeds. So each individual seed is doing very little. It's depending on all the other seeds to get a nice homogeneous or even dose throughout the prostate. We mentioned that every once in a while one seed might escape outside of the prostate and get into the bloodstream through the venous circulation. It's important to realize that each individual seed does very little. So if it migrates somewhere else in the pelvis or even distantly in the body, it's not going to cause any harm. And it doesn't lower the effectiveness of the implant. People ask, who are good candidates for brachytherapy? We're mainly looking at men with low to low intermediate risk disease. So again, the lower the risk of the disease, the less likely the cancer is at the edge of the prostate. As I told you, the seeds don't kind of work very far. They're very kind of finite in their distance of radiation. So if the cancer is localized, we believe it's localized based on it being low risk, then a person would be a good candidate for the brachytherapy. However, if you've got a high PSA or high Gleason and we think there's more chance that the cancer is at the edge or outside the edge of the prostate, then brachytherapy is not a good option. So we generally say that if your PSA is less than 10 and you have a low Gleason score, like a 3+3 or a 3+4, you're a good candidate. Beyond just the specifics of the cancer, there's some other things that we look for. People that have good urinary function are generally those that tolerate the seed implant better. So if you have a lot of urgency and frequency and problems like that, even before any treatment, you're going to be one of those people who's at higher risk to develop complications after a brachytherapy implant. So we generally steer those patients away from seed implant. If you've got a really large prostate, and your urologist could tell you if you do, based on the ultrasound that you've already had for your biopsy, it can make the seed implant difficult either because it would take too many seeds or the prostate might be blocked in some way by some of the bones in the pelvis. And finally, if you've had any prostate operations in the past, especially the TURP or Roto-Rooter, we don't think you're a good candidate for brachytherapy. It's basically like trying to implant a donut where the donut is almost entirely made of the hole. So Again, anyone who's had any prior prostate operations, especially the TURP, is not a good candidate for brachytherapy. What are some advantages of brachytherapy? I'll talk about external radiation a little bit later, but it kind of combines some of the advantages of surgery and external radiation in that it's a one-time procedure, but because the radiation is working from the inside out rather than the outside in of external radiation, there tends to be less damage to surrounding tissues, like the bladder and the rectum. And then one kind of puzzling thing for us is we've anecdotally have seen that erectile dysfunction may be a little bit better with the brachytherapy, but it's very important for me to let you guys know that there's no randomized trials or studies comparing surgery, external radiation, and the seed implants in terms of outcomes, including erectile dysfunction. So I often tell people this might be a self-fulfilling prophecy where people hear this, and if you have good erectile function, you gravitate towards this procedure. And again, the better the patients are going into a certain treatment, the better they're going to be compared to others on the opposite side. For example, with external radiation, we tend to get much older men who already have poor erectile dysfunction. But we mention this because some investigators have seen that erectile function may be a little bit better with the seed implant compared to the other options. What are side effects of brachytherapy or the seed implant? The main ones are urinary, such as frequency and urgency, and maybe some pain with urination. The majority of people, about 85% of people, go home that same day from the seed implant without a catheter. But about 15% of people, because of swelling of the prostate or blood clots, may need to go home with a catheter for a few days. Some men may need urinary medicines to help with symptoms such as frequency and burning. A little less common, but some people can have trouble with their bowels. Whether it's from the anesthesia or just the implant itself, you could be tired. I think one of the biggest questions people have are you going to be safe around other people carrying radioactive material in your body? So important to remember that the bones of the pelvis tend to block out most of the radiation dose from the sides and the back. It's really only from the front that there's any appreciable radiation. And as I told you, the seeds are degrading very quickly. Half of the energy is gone every 2 months. So we just ask that you don't have pregnant women or children on your lap or directly in front of you for extended periods of time in the first couple months. But sitting next to your spouse or partner or lying in bed next to your spouse or partner, even immediately after the implant, there's really no danger from the radiation that you're carrying. Going to the airport, tens of thousands of men have had this procedure, so airport security is very adept at figuring out people that either because of the metal or because of the radiation are tripping the detectors. Long-term side effects from brachytherapy. So some men, even months or years after the treatment, may have trouble with their stream, urinary stream being weaker. They may always notice some stinging with urination. They may need to stay on urinary medicines long term. Some people can get scar tissue in the urethra, sometimes even requiring a procedure to clear some of that. As I mentioned, there is erectile dysfunction from brachytherapy. Rectal injuries are rare with brachytherapy, but they can happen. And we know with any type of radiation, even a therapeutic or treatment type of radiation, it can cause a cancer. The chance of radiation caused by brachytherapy is about 1 in 1,000, and on average it takes 10 to 20 years to happen. If you decide you'd like to pursue brachytherapy, we do all of our procedures in Roseville near Sacramento. The reason we do that is so that the doctors who do it can stay very active and keep their proficiency up. It's one of the busiest centers in the country, doing several hundred cases a year. If you wanted to go through the process of doing the seed implant, you'd attend a class like this in Sacramento, in Lincoln actually first, just to learn a little bit more about the procedure. It's much more focused on brachytherapy than this class. And then you'd need to go back to Sacramento, that area, to plan the implant and actually have the implant done. But then all of your follow-up would be done back here by your local urologist. So once the implant is done, there's no need to return to the Sacramento area. And again, I mentioned it's an outpatient procedure, usually done in the morning or early afternoon and home the same day. I'm going to go ahead and talk about external radiation, but as I said earlier, I will take questions about everything when I switch over to Dr. Schulman. This is just a picture of our center in Rohnert Park where we do external radiation treatment. We take care of patients from both Kaiser Santa Rosa and Kaiser San Rafael. It's a picture of a linear accelerator, a machine that makes radiation. Basically, it accelerates electrons to the speed of light and bombards it against metal, creating a particle called a photon, P-H-O-T-O-N. and that's aimed at the patient. So it's hard to see here, but there's a table that a patient would lie down on, and the radiation would come from the head of the machine down at the prostate. The machine can also rotate 360 degrees and aim from different directions. I'm going to come back to this picture in a second. This picture is a picture of a CAT scan of a patient. Not so important that you understand what's going on here. The main reason for showing you this slide is to show you that all radiation is planned individualized for people. We do a CAT scan before the treatment. A doctor will draw in where your prostate is, but they'll also draw in where your rectum and bladder and other normal structures are, figuring out an array of angles to aim the radiation, maximizing the dose to the prostate and minimizing the dose to normal structures. We know the prostate can move day to day. One thing that we ask urologists like Dr. Schulman, Dr. Balani to do is before the radiation is done to put 3 non-radioactive gold seeds in the prostate. So this is very different than the brachytherapy. The seeds are put in very similar to the biopsy. And you might be able to see these little specks here. So each day before the radiation treatment, and I'll go into a number of treatments in a moment, we basically take films, find where the seeds are, which is basically saying where is the prostate that day, and we'll adjust the beam of the radiation so we're aiming at the correct spot. We know the prostate can move based on how much air or stool is in the rectum or how much urine is in the bladder. So it's just a way of targeting day to day. In terms of the specifics of radiation, it's a daily treatment Monday through Friday for about 7.5 weeks. And the treatments are very quick. They take about 10 to 20 minutes. Our center is open approximately 7:30 to 5 every day. That patient's walking in, walking out, every 15 minutes getting treatment. In terms of the side effects of external radiation, they're very similar to the brachytherapy side effects. But the difference is with brachytherapy, the side effects tend to be the day of the implant and go down with time. With external radiation, they tend to build up in crescendo over those 7.5 weeks. So the same burning frequency and urgency with urination tends to be a little bit more in the way of bowel symptoms like urgency and frequency. There's a little bit of tiredness with radiation, but nothing debilitating. And hair loss is just in the area of treatment, if that, so no hair loss on the head. Long-term side effects months or years after the external radiation is done, what are things that we see? So the radiation can scar the bladder a little bit, so people may not be able to hold as much urine. You may have to urinate more often. You might get some strictures or blood in the urine. Just like the brachytherapy, you may need to be on urinary medication long-term. The back of the prostate and the front of the rectum are right next to each other. And about 10 to 20% of men, they can have damage to the rectum, which can result in minimal volume, intermittent, permanent rectal bleeding. So, for example, a man might notice a drop or two of bright red blood on the toilet paper or on the stool, maybe once or twice a week, and that could last for years, or maybe even for their lifetime. The chance that the bleeding would be so severe that you need a blood transfusion or an operation is very low, 1% or less. Erectile function, we basically say there's about a 50-50 risk of having erectile dysfunction with external radiation. Again, the better your erectile function is before, the better your chances are after. The difference compared to surgery is that it tends to be a slower decline over a few months or years rather than immediate change. And more men tend to kind of respond to medications, oral medications, compared to surgery-induced erectile dysfunction. Like brachytherapy, there is a risk of causing a cancer. It's a low risk, 1 in 1,000. It typically takes 10 to 20 years. We're dealing with the population, older men, where those risks are very low, and a lot of men at the age that we treat may not have a 10 to 20 year life expectancy, or at least 20 year, I should say. Someone had asked about proton radiation earlier. All the radiation I was talking about just previous was photon, P-H-O-T-O-N. This is P-R-O-T-O-N. For many years, there were 2 proton centers in the country, Loma Linda in Southern California, and then also Mass General in Boston. There's about half dozen to a dozen new centers that have opened over the last 5 years. Basically, protons, if you remember from your high school physics, it's that particle in the middle of an atom. And that can be used to deliver the radiation just like a photon is used. Biologically, it does the same thing. The only difference is there tends to be less radiation dose around the organ that you're treating with protons rather than photons. But most importantly, there's no difference that's been shown in any study that protons are superior to photons in terms of controlling the disease, or side effects. The closest facility, as I mentioned, that offers proton treatment is in Loma Linda. And because there's no evidence of any benefit with proton treatment, patients that opt for this would do this out of pocket. Again, 99% or more of the centers in this country don't use protons. UCSF, Stanford, UC Davis, all of the other community hospitals in this area. There are some applications for protons, especially in treating children with cancer that get radiation. Some of those characteristics of having less dose around what you're trying to treat can be very useful for kids. But I think in terms of prostate, if there's any difference, it would be very small. And I think I'm not sure kind of what the future is for protons in this country, because it's also a very expensive treatment. I'm going to finish up talking about antihormonal therapy. This is something that's unique only when people choose external radiation when they have intermediate and high-risk disease. It's basically a treatment that's used to lower the testosterone because testosterone is a growth factor for prostate cancer. So in men with intermediate and high-risk disease that choose external radiation, we'll often recommend adding antihormonal therapy. For men with intermediate risk disease, it's 4 to 6 months of antihormonal therapy, starting a couple months before the treatment. For men with high-risk disease, we may recommend even longer-term treatment, sometimes up to 2 to 3 years. Why do we use antihormonal therapy? There are studies that show that in men getting external radiation with intermediate to high-risk disease, lowering the testosterone, which lowers the activity of the prostate cancer, leads to better prostate cancer outcomes. And we see that the younger the patient is and the shorter amount of time we use antihormonal therapy, the better the chance the testosterone comes back afterwards. That's a good segue to talk about what are side effects of using antihormonal therapy. When we give antihormonal therapy just for a few months, the things that we typically see are sexual dysfunction, not being interested in sex, and hot flashes, kind of like a male menopause. This usually resolves after the treatment is done. If we give antihormonal therapy for long periods of time, in the years, another way of saying this is what happens if you take away a man's testosterone for a long period of time. See things like osteoporosis or bone weakening. People can have anemia or low blood counts. People tend to lose muscle, gain fat, have higher risk of getting diabetes. And sometimes people can become depressed when you change their testosterone levels for a long period of time. One question people have is, what happens if the cancer comes back after I have radiation treatment? What happens if the PSA rises after radiation is done? Typically, we don't recommend surgery. There tends to be a lot of risk in terms of, because of scar tissue caused by the radiation. It could cause a rectal injury, cause urinary injury, including incontinence. And we typically can't give more radiation. We try to give as much radiation safely up front, not reserving something in case the cancer comes back. The main things that we look at in terms of treatment if the cancer comes back after radiation is freezing the prostate or cryotherapy, or the same antihormonal therapy that I was talking about that can be combined with radiation can also be used as a salvage or backup if the cancer comes back.